Hey everyone, I'm Mohammed Hamama, and welcome to your ASCP preparation camp. Today, we're on the third and final episode of carbohydrates before we start explaining diabetes millets in the next episode. Today we will discuss lactate and pyruvate, methods for measuring lactate and pyruvate in body fluids, inborn errors of carbohydrate metabolism, and glycogen storage disease. But first, don't forget to hit that like button, subscribe to stay updated, and share it with friends who are also studying. And by the way, our ASCP short notes are now available in easy-to-digest chapters, so check them out in the link below. Let's start with lactate. What is lactate? Lactate is an important intermediate in carbohydrate metabolism. It's produced primarily in several areas of the body, including white skeletal muscle, the brain, skin, the renal medulla, and even in our red blood cells. But what determines the levels of lactate in your blood? Two main factors: how much is produced in these tissues and how efficiently it's metabolized, especially by the liver and kidneys. In fact, 65% of the lactate produced in your body at rest is used by the liver, primarily for a process called gluconeogenesis, where lactate is converted back into glucose. This process is a part of the Cori cycle, a system where lactate produced in muscles is taken up by the liver and turned back into glucose, which can be sent back to the muscles for energy. But what happens when lactate levels rise? When lactate production outpaces the liver's ability to process it, like when plasma concentrations exceed 2 millimoles per liter, the liver's capacity to clear lactate becomes saturated. This can lead to a condition known as lactic acidosis, which occurs in two types. Type A, which is linked to lack of oxygen, hypoxia. Type B, which results from metabolic issues. Lactic acidosis is serious, affecting about 1% of hospital patients with a mortality rate exceeding 60%. It's a condition doctors closely monitor, as it can be life-threatening. Now let's talk about pyruvate, another essential player in metabolism. Pyruvate is mostly produced from glycolysis, the process your body uses to break down glucose for energy. Once produced, pyruvate can be metabolized in four ways, depending on what your body needs. 1. Through alanine aminotransferase, which helps balance amino acids. 2. Pyruvate carboxylase, which helps produce new glucose. 3. Lactate dehydrogenase, which converts pyruvate to lactate and vice versa. 4. And lastly, pyruvate dehydrogenase, which converts pyruvate into acetyl-CoA, a crucial component for energy production. One of the most useful things about measuring pyruvate in medical settings is its connection to lactate levels. Doctors often look at the lactate to pyruvate ratio to diagnose metabolic conditions. For example, a ratio below 25 might suggest a defect in gluconeogenesis, meaning the body struggles to make glucose. A higher ratio, around 35 or above, points to hypoxia, a condition where tissues aren't getting enough oxygen. Clinical significance of lactate and pyruvate. Why do we care so much about lactate and pyruvate? These metabolites are key indicators for diagnosing and managing a range of diseases, from inborn errors of metabolism to lactic acidosis and even mitochondrial disorders. By measuring the levels of these molecules, doctors can track the progress of treatments and predict outcomes in patients with metabolic and mitochondrial issues. Plus, they can also analyze cerebrospinal fluid, CSF, levels of lactate and pyruvate to diagnose neurological disorders like cerebral vasospasm and meningitis. How do we measure lactate and pyruvate? Measuring lactate and pyruvate levels in the blood is crucial for diagnosis. Let's start with lactate. The enzymatic method is the most common way to measure lactate. In this method, lactate is converted into pyruvate by an enzyme called lactate dehydrogenase in the presence of NAD+. As this reaction occurs, NADH is produced, and the amount of NADH is measured using a spectrophotometer at 340 nanometers. This gives a precise reading of lactate concentration in the blood. Some labs also use other methods, like gas chromatography or photometry, but the enzymatic method is considered the most accurate and preferred. For pyruvate measurements, the process is essentially the reverse. Pyruvate is converted back to lactate, and this reaction can be measured with the same level of accuracy. It's done at a pH of 7.5, and the method is highly specific, ensuring no interference from other substances like oxaloacetate or 2-oxyglutarate. Finally, let's talk about reference intervals, the normal range of lactate and pyruvate levels. These can vary depending on where the sample is taken from, such as venous blood, arterial blood, or cerebrospinal fluid. For instance, in fasting venous blood, normal lactate levels are between 0.3 and 0.9 mg per deciliter. In arterial blood, the range is slightly lower, at 0.2 to 0.7 mg per deciliter. And in CSF, lactate levels typically range between 0.5 and 1.7 mg per deciliter. Knowing these reference intervals helps clinicians determine whether a patient's lactate or pyruvate levels are within normal limits or indicate an underlying issue. Inborn errors of carbohydrate metabolism, rare but significant disorders that can have serious health consequences if left untreated. The most important inborn errors of carbohydrate metabolism is galactose, fructose, and pentose metabolism disorders. Overview of carbohydrate metabolism disorders. At the core of these disorders is a problem with enzymes, the proteins that help our bodies process carbohydrates. When one of these enzymes is deficient or absent, it can lead to an accumulation of sugars, like monosaccharides, in the body. And in some cases, these sugars spill over into the urine, a condition known as glycosuria. Most of these conditions are inherited as autosomal recessive traits, meaning that both parents must pass on the faulty gene for a child to be affected. Now, it's important to note that finding sugars in the urine doesn't always point to a disease, sometimes it's simply the result of excessive sugar consumption. But when it comes to inborn errors, the presence of certain sugars can be a crucial diagnostic clue. Let's start by talking about galactose metabolism. Galactose is a sugar found in milk that's converted into glucose through a series of enzyme-driven reactions. When one of these enzymes is missing, it leads to a condition called galactosemia. There are three main types of galactosemia, each caused by a deficiency in a different enzyme. 1. Galactose 1-phosphate uridyl transferase deficiency, the most common form. 2. Uridine diphosphate galactose 4-epimerase deficiency. 3. Galactokinase deficiency. Let's break down each of these. Galactose 1-phosphate uridyl transferase deficiency. This is the most common form of galactosemia, affecting about 1 in 30,000 to 1 in 60,000 newborns. Infants with this condition often fail to thrive on milk and can develop serious symptoms, including vomiting, diarrhea, liver disease, cataracts, and even mental retardation in severe cases. Sometimes, these infants may also experience hypoglycemia, or low blood sugar. Diagnosis is made by detecting elevated levels of galactose and galactose 1-phosphate in the blood. This can be confirmed by testing the activity of the enzyme in red blood cells. Treatment is straightforward, removing galactose from the diet. Early detection and treatment are critical to avoid long-term complications. Uridine diphosphate galactose 4-epimerase deficiency. This is a rarer form of galactosemia, with a higher prevalence in certain populations, such as 1 in 7,000 among African Americans and 1 in 70,000 in whites. The symptoms are similar to those seen in transferase deficiency, including failure to thrive and liver dysfunction. Galactokinase deficiency. Galactokinase deficiency is a milder form of galactosemia, affecting about 1 in 100,000 to 1 in 150,000 individuals. Its main symptom is the development of cataracts in infancy, caused by the accumulation of a substance called galactitol in the lens of the eye. This can be diagnosed by testing for normal transferase activity but an absence of galactokinase in red blood cells. Now, let's move on to fructose metabolism. Fructose is found in foods like fruit, honey, and syrups, and under normal conditions, some fructose may appear in the urine after eating these foods. However, this is typically harmless. But in some cases, there can be underlying inborn errors of fructose metabolism that cause more serious problems. There are three main disorders of fructose metabolism, all inherited as autosomal recessive traits. The first disorder is essential fructosuria. This is a rare, harmless condition caused by a deficiency of the enzyme fructokinase. People with this disorder are asymptomatic, and it's often discovered incidentally during routine urinalysis when reducing substances, like fructose, are detected. The amount of fructose in the urine depends on how much fructose or sucrose the individual consumes, but overall, this condition doesn't cause any health problems. The second, and more serious, disorder is hereditary fructose intolerance. This condition is caused by a deficiency of the enzyme fructose 1-phosphate aldolase. It's more severe, with an estimated incidence of 1 in 20,000 in the UK. Ingesting fructose in affected individuals can lead to severe hypoglycemia, liver failure. This occurs because fructose blocks both glycogen breakdown and gluconeogenesis, leading to dangerously low blood sugar. The condition can be managed by avoiding sucrose and fructose in the diet, but early diagnosis is key. The third disorder is hereditary fructose 1,6-diphosphatase deficiency, which causes an even more severe block in gluconeogenesis. Affected individuals may experience apnea, temporary cessation of breathing, hyperventilation, hypoglycemia, ketosis, and lactic acidosis. Diagnosis is made by testing liver biopsy samples or performing genetic analysis. Treatment typically involves dietary management to prevent fructose intake. Finally, we'll cover pentose metabolism. Pentoses are found in fruits like cherries, plums, grapes, and prunes. Sometimes, consuming large quantities of these fruits can lead to pentoses appearing in the urine, a harmless condition known as alimentary pentasuria. However, there's also a metabolic disorder called essential pentasuria. Essential pentasuria. Essential pentasuria is a benign condition that affects the glucuronic acid oxidation pathway. It's caused by a deficiency of L-xylulose reductase, an enzyme that normally helps metabolize pentoses. The condition is rare, affecting about 1 in 40,000 to 1 in 50,000 people in the U.S. It leads to the excretion of 1 to 4 grams of L-xylulose in the urine each day. Importantly, because the glucuronic acid pathway has no essential role in human health, this condition is completely harmless. Urinary sugars and their detection. Sugars in the urine might seem alarming, but they aren't always a sign of disease. Certain sugars can appear in urine under specific conditions. Lactose might be detected in the urine of women during pregnancy or lactation. For people with lactase deficiency, commonly known as lactose intolerance, lactose can show up in the urine, alongside symptoms like abdominal pain and diarrhea. Maltose has also been detected in the urine of some patients, although this is quite rare. Interestingly, not all reducing substances in urine are sugars. For example, ascorbic acid, also known as vitamin C, can also be found in the urine, potentially interfering with certain tests. Methods for measuring individual sugars. To detect and differentiate various sugars in urine, scientists use a variety of tests. Let's go over some of the key methods. Glucose oxidase test strips are the most commonly used method to specifically detect glucose in urine. These strips are highly specific and can distinguish glucose from other reducing substances. For infants and children, both glucose oxidase and copper reduction tests are used. This dual testing approach helps identify inborn errors of metabolism, such as galactosemia or hereditary fructose intolerance. But how about detecting sugars other than glucose? Qualitative tests for non-glucose sugars. There are specialized tests for different sugars. Fructose can be detected using the Selivanov test, where heating urine with HCl and resorcinol produces a red color if fructose is present. Pentoses, a type of sugar found in certain fruits, can be identified using the bile test. This test heats the urine with HCl and orcinol, resulting in a green compound when pentoses are present. Before testing for pentoses, it's important to remove glucose by fermentation with yeast to avoid interference. Chromatography techniques for identifying sugars. In some cases, scientists need to separate and identify individual sugars. They use a process called chromatography, which can either be done on paper or using a thin layer. Paper chromatography. This technique allows for the separation of sugars on a paper strip. After the sugars are separated, they can be visualized using dinitrosalicylic acid, and the results are compared to reference compounds. Thin layer chromatography. This method is often preferred over paper chromatography because it's faster and more efficient. It's especially useful when frequent separations are needed. Now that we've covered urinary sugars, let's switch gears and talk about glycogen storage diseases. What are glycogen storage diseases? Glycogen storage diseases, GSDs, are a group of rare, inherited disorders that affect how the body stores and uses glycogen, a key energy source. There are at least 12 different types of GSDs, each caused by a deficiency in a specific enzyme involved in glycogen metabolism. The most common types are: Type 1, glucose 6-phosphatase deficiency. Type 2, acid alpha-glucosidase deficiency. Type 3, amylo 1,6-glucosidase deficiency. Type 4, branching enzyme deficiency. Type 5, muscle phosphorylase deficiency. Type 6, liver phosphorylase deficiency. Type 7, muscle phosphofructokinase deficiency. Let's break down each of these types and what they mean for patients. Type 1, glucose 6-phosphatase deficiency. Type 1 is the most common and severe form of glycogen storage disease. Patients with this condition have glycogen accumulation in the liver, causing symptoms like massive hepatomegaly, enlarged liver, growth retardation, fasting hypoglycemia, low blood sugar when not eating, increased lactic acid levels in the blood, hyperuricemia, high uric acid levels, hypertriglyceridemia, high triglyceride levels. Treatment usually involves frequent meals and nasogastric feeding at night to maintain stable blood sugar levels. Type 2, acid alpha-glucosidase deficiency. Also known as Pompe disease, type 2 primarily affects the heart and skeletal muscles. Patients experience muscle weakness and cardiomegaly, enlarged heart, but their liver function is typically normal, and they don't experience hypoglycemia. There are two forms of this disease. The infantile form, which presents early in life. The juvenile form, which shows up later. Type 3, amylo 1,6-glucosidase deficiency. Type 3 affects both the liver and muscle due to a deficiency in the glycogen debranching enzyme. Patients often develop hepatomegaly and muscle weakness, and their symptoms resemble those of type 1. Type 4, branching enzyme deficiency. This is a rare and severe form of GSD where patients produce an abnormal type of unbranched glycogen. It leads to hepatosplenomegaly, enlarged liver and spleen, ascites, and eventually liver failure. Type 5, muscle phosphorylase deficiency. Also called McArdle disease, type 5 usually presents in the second or third decade of life with muscle cramps after exercise. Patients have high plasma creatine kinase levels at rest, and their muscles don't produce enough lactate during exercise, leading to exercise intolerance. Type 6, liver phosphorylase deficiency. Type 6 is a milder form of GSD, with patients exhibiting hepatomegaly due to increased glycogen storage in the liver. Diagnosis is made by testing enzyme activity in the liver or blood cells. Type 7, muscle phosphofructokinase deficiency. Lastly, type 7 affects muscle glycogen metabolism and leads to exercise intolerance. Similar to type 5, patients also have abnormal glycogen deposits in their muscles and may experience hemolysis, breakdown of red blood cells, during exercise. Don't forget to hit the subscribe button and turn on notifications so you never miss a new video. Share this with anyone who could use a little extra support in their studies. And if you have any questions, drop them in the comments below. I'd love to hear from you. Also, don't forget to check out our ASCP short notes in the store to boost your preparation. Thanks for watching, and I'll see you in the next one. Keep learning, and good luck.